Good evening. Thank you for joining us today. My name is Dr. Shaunak Desai. I'm from the Newport Orthopedic Institute, and I'm here to talk a little bit about treatment options for carpal tunnel syndrome, which is a very common problem in the hand, but commonly misunderstood problem as well. A little bit about myself. I am in practice now for 10 years at the Newport Orthopedic Institute. I am an orthopedic trained hand surgeon. I did my orthopedic residency at Henry Ford Hospital in Michigan and did my fellowship in hand and upper extremity surgery at Stanford University. And finished up in 2010, and I've been in practice since then at the Newport Orthopedic Institute. My specialty is hand and upper extremity, and I'm here to talk to you a little bit about a common problem I deal with on a day-in, day-out basis, carpal tunnel syndrome. So I have a lecture here set up for you. And essentially, we're going to do is we talk about common orthopedic terminology. I think it's always important to do that when we talk about the hand and other problems in orthopedics. Essentially, common things: tendons. What are tendons? Muscle connects muscle to bone. Ligaments are bone to bone. Joints are two spaces between bones, and obviously nerves carry signals from the brain to the peripheral nervous systems, and there's also a sensation and a motor component to those. Common things to think about too is itises. What does that mean? You hear a lot about tendinitises, arthritises, neuritis, and that's how doctors talk. Essentially, it just means inflammation of something. And you have a tendinitis, means inflammation of the tendons. Arthritis is an inflammation of the joint, and then a neuritis is an inflammation of a nerve. The anatomy of the hand is pretty complex, and that's kind of why I chose my field of hand surgery. It is a complex anatomy, and it's a fine interplay between the nerves, arteries, and tendons. And so to understand the anatomy is to understand the syndromes that are associated with it. And one of those things that we see on a regular basis is nerve compression or nerve problems. So here's just some basic anatomy. Obviously, here's the bones in the hands. This is a complex cartoon anatomy of the hand on your slide on your right, showing there's a lot of things going on in the hand, and trying to figure out what's causing what and what's hurting what is important to do. So what is carpal tunnel syndrome? Well, essentially, I think carpal tunnel gets misdiagnosed for a lot of things. People think that it's pretty much the cause of all your problems in your hands, and unfortunately, it is not. And so the biggest thing about carpal tunnel is understanding what it really does. And it really means compression of the nerve at the level of the wrist. And when the nerve gets compressed, it leads to that particular nerve dysfunction or not working. And so essentially, we're going to go over what it is, how to treat it, how to diagnose it, and what to expect afterwards. So exactly what is the median nerve? Because essentially carpal tunnel syndrome is compression of the nerve at the level of the wrist. And so at the level of the wrist, what does the median nerve do? Well, it provides sensation in about 3.5 digits in your fingers: the thumb, the index, the long finger or the middle finger, and half of your ring finger. Now there are some variations in anatomy, and so that's some people have different variations in that sense. And it actually kind of innervates the muscles to your thumb. That's called your thenar muscles. So it is a pretty common problem. It's probably the most common compression neuropathy in the body, meaning that we see this in a large portion of the population. About 14.4% of the population will eventually get this problem. Women are more common than males to get this, and usually happens in the 5th and 8th decade in life. And as you can see, the working population has an up to a 10% risk of developing carpal tunnel. So there are also some work-related issues with carpal tunnel. The average person who gets a work-related carpal tunnel syndrome is about age 37. Males are slightly more likely to get it than females. However, 40% of people who have carpal tunnel syndrome attributed to work also have other issues and risk factors, such as diabetes, low thyroid functions, and other things in that category. So what are some at-risk occupations? Well, you may have thought that computer work and desk work can cause carpal tunnel. Well, that's not necessarily true. That was probably an older study back in the 80s and 90s. And subsequent studies have shown that carpal tunnel and computer usage or desk work has not a true association. Some of the more common occupations that you see carpal tunnel is being a dental hygienist, working in the supermarket, if you're a checker, or anything that requires any heavy-duty vibration or forceful gripping. So if you're working with chainsaws or jackhammers, stuff like that would possibly cause that. So other risk factors for carpal tunnel syndrome, well, other things that you can see is hypothyroidism, diabetes, if you have recently broken your wrist, and pregnancy can also be some of the main common issues that you can increase your risk for carpal tunnel syndrome. So the anatomy of the carpal tunnel is important, and if you understand that, you do understand what carpal tunnel does then. If you look at this cartoon image on the right-hand side there on your screen, essentially carpal tunnel, there's a nerve that goes underneath a ligament called the transverse carpal ligament. And under that ligament, you can get quite a bit of compression. And with that, it compresses the nerve, and that causes the nerve to not function as well. So here's a cross-sectional anatomy picture. And as you can see, that those arrows are pointing to, the top right-hand arrow is pointing to the ligament itself. And that is the ligament that we release in surgery for carpal tunnel. The cross-section below that, the left-hand arrow, points to what's inside the carpal tunnel. And if you look at that, you can see that the arrow is pointing to the nerve itself. And then around that, those other surrounding circular or oblong structures are actually the tendons underneath there. And so there's a finite space. And so if you have a lot of fluid, or if you, let's say you have tendinitis and it gets inflamed, and then there's not much room for that nerve to kind of have room to breathe, and it gets compressed at that level. And that's essentially what carpal tunnel syndrome is. So what do you feel? Pain on the front of your wrist, or that we call palmar aspect, or the palm aspect of your wrist. It may radiate or tingle to your fingertips, and it can actually go up to the forearm area as well. People describe pins and needles sensation. Some people may have what we call hypothesia, or they feel things more hypersensitive. And the usual fingers that are involved is the thumb, the index, the middle finger, and the ring finger. So exam findings, well, there are a couple exam findings that we do during your examination when you come see one of us as orthopedic hand surgeons. But essentially, they're all tests to determine whether or not you have carpal tunnel. The first one, the easiest one, is a TINEL'S sign, where you tap on the nerve at the level of the wrist, and then you get a shocking sensation down to your fingertips. That's a classic sign for carpal tunnel. What we call our PHALEN'S test, when you have your wrist flexed for a period of time, and it exacerbates some of the symptoms that you have in your fingertips, and that can be a sign as well. This is the median nerve compression test. This is probably the best physical exam test that we have, where you put pressure on the nerve just at the level where that nerve is going to in the carpal tunnel, and then we hold it there for about a minute or so and see if the sensations of numbness and tingling gets exacerbated. And then we check your strength. Like I said, that the carpal tunnel nerve, the median nerve, provides the motor function to the thenar muscles in your thumb. And so we want to check the strength and see if you lost any of that from the nerve compression. Also, obviously, light touch. We just touch the finger there. There's different ways of doing that. We have different tools that can test it, light touch a little better. And then here's a picture showing thenar atrophy. I don't know if you can see that, but on the slide there right below, you can see a little divot in that picture where that thumb muscle should be a little more vibrant. And you can see where that's a little atrophy of the muscle there. So what are your treatment options? Well, like anything in orthopedics, a lot of things is resting, immobilization, bracing, anti-inflammatories. You know, there's therapy, and then cortisone injections and surgery all have a role in treatment for carpal tunnel. Non-operative treatment, you know, obviously activity modification, you know, riding a bike, motorcycles, jackhammer work, well, you know, those are risk factors. Any type of small vibration activities can exacerbate carpal tunnel syndrome. So if we can modify what we're doing, that's important. You may have heard nocturnal splinting, or wearing a brace at nighttime. That's helpful. Essentially, you want to wear a brace that keeps you in neutral position, and we'll talk about that a little bit later. Also, anti-inflammatories like Advil, Motrin, Aleve, those are over-the-counter stuff. You know, there's meloxicam, Celebrex, these are other things out there. Vitamin C, B6, well, there's some thought processes and some early science that say that maybe that might be helpful, but that's a little controversial. And then steroid injections was used to be the mainstay of treatment if you talk to us about 25 years ago, but it has been a little bit controversial now in its role in carpal tunnel. So what are your braces that you can use? Well, essentially a brace that keeps your wrist nice and straight. You don't want to bring a wrist that keeps your wrist backwards. So the one on the right is probably the brace that kind of brings your wrist back about 20 or 30 degrees, which actually can possibly exacerbate the carpal tunnel. The one on the left, that wraparound one, actually keeps your wrist in a slightly what we call neutral position. That's probably a better brace. So that's the one you kind of want to consider using. So cortisone injections, like I said, back in the day, we used to do a lot of these injections, and now we've kind of fallen out of favor. I think they do have a good diagnostic value, meaning that we are in a situation where we're not quite sure if someone has carpal tunnel or not. You could try a cortisone injection and see if that patient will get relief, or if you get relief. And if you do, then we know that your response to doing a carpal tunnel release would be better. Now, there's some controversy whether or not steroid injections just to delay the inevitable, meaning that does the carpal tunnel just gets worse and just makes your symptoms better briefly. And that thought process is valid. There are some studies that kind of show that it may not necessarily make the carpal tunnel better, but might make your symptoms a little better in the process. So these are different steroids that we use. And this is kind of what we do for the injection. We kind of inject it. That's the carpal tunnel right down there. And we're injecting deep into the carpal canal, avoiding the actual nerve itself. So your response to carpal tunnel injections, well, we have a study that shows that after the injection, it does kind of decrease over time. And again, does it really change the natural history of carpal tunnel syndrome? Again, that is controversial. And so the thought process is it may not, and the carpal tunnel may get worse over time. So surgery for carpal tunnel is indicated when the non-surgical things don't work. How do we determine when surgery is important? Well, obviously we try therapy, we try splinting techniques. The next step is to actually get a nerve study. It's an EMG nerve conduction study that's done by our neurologist colleagues. And it determines whether or not what number and how bad your carpal tunnel is. This gives us an objective tool to determine that how badly compressed his nerve is. And when the nerve is anywhere in the moderate zone, or nerve conduction study shows that you have at least moderate amount of carpal tunnel, then we think that surgery is recommended at that point. The reason for that is that if it's in the moderate zone, it tends to get worse over time. And essentially what we're trying to catch carpal tunnel syndrome before it gets so bad that it's not reversible. And so I like to use the garden and the hose mentality. If you have a garden and you take away the water supply for a period of time, your garden starts to wilt. If you catch it in time and you open up that hose and you get that water flowing back to your garden, well, then you have a chance for your garden to grow back. But if you wait too long and that garden slowly wilts and then eventually it dies, then throwing as much water you want at it, i.e. opening up that nerve and trying to get that signal back, it may not necessarily bounce back, and you may not get 100% relief after the carpal tunnel release. So the idea is to catch it while it's still fixable. So what are your surgical options? Well, surgery, there's the conventional open surgery approach, and there's a mini versus an extended incision. And we'll go over about that as well. There are other options as well. It's called the endoscopic carpal tunnel release. So all these things are done usually at an outpatient surgery center. Some places can be done at a procedure room as well. And so there are benefits on each one. And so for the open carpal tunnel release, or I do a mini open specifically, the advantages are that you can actually see the nerve well. There's minimal chance of the nerve injury because you actually can see it. It can be done under a local anesthesia, meaning that we can do it under just a numbing block and no anesthesia whatsoever, i.e. no sedation, no general anesthesia. And you can do other things at the same time. If you need to clean out the tendons, you can do a tenosynovectomy. That's the idea, is to address the tendons if they have any issues at that time. The disadvantages, well, you know, the older studies have shown that maybe you might have a little bit more of a tender scar in this area. Now that we are doing more of a mini open approach, that's not as much of an issue. And so the advantage of the open approach is pretty much a minimal approach, meaning that less anesthesia. It can be done in a safer condition. And so this is an idea of how we're numbing up the hand here. So this is a picture showing you how we inject it with a local anesthetic. And this is us drawing the pictures here. And what we're trying to just show you is how we kind of draw out the lines when we do the carpal tunnel. And essentially what we're doing is the picture on the right, which is in block there, just shows us our incision here. And essentially this is our incision for our carpal tunnel release. And so you can see it's relatively small. The carpal tunnel is in the palm of the hand and not so much in the wrist. And we can see where our little hash marks are is where my stitches will go, and usually about 3 stitches in total. So not a very big incision. And this is what we do for a mini open carpal tunnel release. And again, this can be done under local anesthesia alone without any sedation. So this is us releasing, and then right below there, you can actually see the nerve. We have released the ligament. That's on either side of those leaflets. And deep, deep inside there is the nerve itself. And you can see that nerve is a little flattened because it's being compressed there. But now you can see how it's now opened up and has more room to breathe, so to speak. So. And this is our closure afterwards. So again, 3 tiny stitches there. This patient actually had a trigger finger release as well. So she had some stitches in for a trigger finger release, which we hide in the crease of the hand there. So, so that's afterwards when we're done. So not a very big surgery. And the dressings are pretty minimal as well. So this is just a bigger approach. This is a more of an extended carpal tunnel, but this actually gives you an idea, and I'm going to show you these slides just to give you an idea how the nerve looks when you have a severe carpal tunnel. And this is what a little bigger incision for a patient who had a more of an extended approach given the severity of the symptoms. And so this is the ligament that we're releasing. You can see I've released part of it already, and there's just a little bit left here. And then if you look at that nerve, this is an extended carpal tunnel release. You can see how red that nerve is. You can see it all the way going across and how flattened it is. Again, this is an extended carpal tunnel. This is not your standard carpal tunnel release. This is a patient had other issues, and we had to go in there for other issues for this. But this is how the nerve looks with if you have a severe carpal tunnel. And this is a close-up. You can see that nerve itself, and see how it's flattened right in the middle there. And you see how there's redness on the nerve itself, where you see some red strands or blood vessels that are going through the nerve. And this is a patient who had a very severe carpal tunnel syndrome. So there's an endoscopic approach, which is an approach that we do as well. The benefit of the endoscopic approach, well, it is technically a smaller incision. The scar is in a different location, so technically it's less technically painful. Now that debate is out in terms of that. But the problem with this is that you have to have more sedation for this. This is one that we kind of have to provide you more general anesthesia or heavier sedation for it. Because it is harder to do this one under a local anesthetic alone. And so there's different approaches to do an endoscopic. There's a single approach, different approaches. There has been a thought process that because you're not directly seeing the nerve, there's a little bit higher risk of nerve injury with this approach, and also a little higher risk of an incomplete nerve release. So those are some of the downsides with the endoscopic approach. And this is just a cartoon drawing of one system of what we use. And you can see where that incision is. It's in the crease of the wrist and not so much in the palm of the hand. And essentially, you're releasing the nerve indirectly with a camera. And it's a valid approach in terms of doing this, but it does require a little more anesthesia to do this. Some other controversial issues. Some people have talked about laser treatment for carpal tunnel. Well, there really isn't a role for that. Studies have shown that it damages the nerve, and most hand surgeons across the country don't do this. Acupuncture, acupressure is not that helpful, and so those things are not supportive as well. So those are issues that consider out there that are not supported by the evidence itself. So. All right, and so that's pretty much my talk in a nutshell. I know you have some questions, and so I'll address those next. If you have any issues or questions about things, this is my appointment scheduler as well. You can contact her offline and she can direct those questions to me. But I think we'll go on to the questions next and see if I can address some of them for you. All right. So I think a couple of these came through the chat box. So the first question I got here is, does trigger thumb have any connection to carpal tunnel syndrome? That's an excellent question. So trigger fingers and carpal tunnel syndrome go hand in hand, no pun intended. They are very similar problems. Now, there are different problems. And so one is affecting the thumb and the tendon to the thumb, or the finger if you have a trigger finger. So it's tendinitis. And it's causing locking and popping of the finger as you move. The other one is carpal tunnel syndrome, which is compression of the nerve. Now, what is the cause of carpal tunnel syndrome? Well, we said compression of the nerve. And what causes compression of the nerve? Well, pretty much tendinitis or inflammation can cause that. And so the issues of inflammation is somewhat the same. So people who have trigger fingers tend to have higher incidence of having carpal tunnel, and vice versa. People who have carpal tunnel are more likely to get trigger fingers. So it is the same quote-unquote pathophysiology. But they are two separate issues. All right, so hopefully that answered your question there. So I have a twofer on this one. What is my opinion on someone with both trigger thumb and trigger finger? Have you treated both successfully? So the answer is yes. We actually do trigger fingers and carpal tunnel releases at the same time. In fact, it is a pretty common thing to do at the same time. And so both can be done at the same stage. And the treatment is the same. If we do an open carpal tunnel release, we can do it under a local anesthesia, or we can do it with a light sedation, definitely a patient choice, but this is not something that needs general anesthesia for. And so both surgeries can easily be done at the same time. So the answer is yes to that. So the other questions I got here, are there any exercises that can be done to avoid carpal tunnel syndrome? That is a good question. Therapy in carpal tunnel syndrome has shown some benefit with some physical therapy, and there are some things that you may be able to find online that might be helpful. How beneficial it is in terms of staging off carpal tunnel is somewhat controversial. I think that benefit of therapy is to help decrease inflammation in the wrist and hand, and there's some theory behind that. But I do think that overall therapy has a role. Its role has been somewhat debunked lately with certain studies showing that it may not be as effective as we thought it was maybe 10 years ago. So yes, I do think therapy can be helpful. How successful is it? Well, I think it kind of depends on what stage of carpal tunnel syndrome you have. If you're in the mild cases, I think it might be more effective. If you're in the more moderate to severe cases, may not be as effective. All right, and I got one more question here. Oh, we have some more coming. Okay, very good. So, will a vertical mouse or an ergonomic keyboard help if we are working from home? That's a good question. I think nowadays with this whole staying at home and with the COVID situation, and we're working at home a lot more online and Zooming, I think there has been a lot more concern of carpal tunnel syndrome and ergonomics. In reality, like I said, in terms of carpal tunnel syndrome in computer work or desk work, again, a study has been shown that it hasn't been proven that carpal tunnel syndrome and desk work has a correlation. Now, can it exacerbate symptoms? Yes. Now, is it the etiology of carpal tunnel? The answer is no. And so I do think that having an ergonomic workstation is helpful to help decrease other issues that you can get in the hand, which is tendinitis. If you do have arthritis in your hands, that can be helpful for that. I do think that there are some roles if you are doing certain things that require a lot of forced wrist flexion. Then an ergonomic workstation evaluation is helpful with an occupational therapist. They can actually go over that in their office with you and tell you how to properly set up your workstation so you do some things that are beneficial and not pick up bad habits in terms of our ergonomic usage. So the answer is, yeah, I do think that there is ways and tools that can help you with hand pain, specifically related to working at home and working at the desk. So, all right, and I get another question here. How can I manage pregnancy-induced carpal tunnel syndrome that seems to be getting worse? Well, that's a good question. So pregnancy carpal tunnel syndrome is actually a different issue. It is fluid from pregnancy shifting that goes into the carpal tunnel and actually compresses the nerve. The good news is most pregnancy-related carpal tunnel syndrome will go away after you give birth. And there's almost a dramatic improvement after you do so. It's usually worse in your third trimester. And it is miserable, and there's no doubt about it. And so what can you do? Well, wearing a brace at nighttime has been helpful. Sometimes your OB will recommend doing so. But even if that doesn't work, then yes, you can actually get a cortisone injection. That is one of those roles where a cortisone injection would be very beneficial. So we do that not uncommonly for patients who do have pregnancy-related carpal tunnel syndrome, especially in their third trimester. So yes, a cortisone injection could be helpful. If you're miserable and it's keeping you up at night, I think there would be a role for that. And I guess the second part of that question is just a brace and therapy, and I am 29 weeks pregnant. Well, congratulations. Yeah, so a brace is helpful, and like I said, I think therapy is somewhat successful. I think it can't hurt for you to do it. I think if you are miserable, I would talk to your OB first. But I do see patients regularly who have pregnancy-related carpal tunnel syndrome, and we can easily do a cortisone injection, and that would help you, give you some relief until you give birth. So, all right, hopefully that have answered your question there. All right, and I think we have one more. Okay, let's see. So is surgery the only remedy for a trigger thumb? Questions for trigger fingers today. So, so the answer is no. A trigger finger or trigger thumb, what are your options for those? I know we didn't talk about that in this talk, but anti-inflammatories are helpful. Advil, Motrin, Aleve are definitely helpful. And we can do a cortisone injection. A cortisone injection has about a 50 to 70% chance of curing the problem. And so we can do an injection one time, and then if it doesn't work, we can do an injection again in about a month. Our limit is usually 2. If it doesn't work by the second injection, we don't think the third, fourth, and fifth will necessarily work. And also, if we keep injecting the tendon, then obviously there's a risk of tendon damage. So we at least try 2 injections, or the recommendation is to try at least 2. And if that doesn't work, then there is a surgery for this. It is a 5-minute surgery under local anesthesia, very similar to carpal tunnel, where we can release that trapped tendon. So it is a pretty simple problem to address. But no, the answer is yes, you can try a cortisone injection, you can try anti-inflammatories for a trigger finger, and those are the mainstay of treatments first. Okay. All right, any other questions? Okay, I guess another one here. So what is the chance of repeat surgery? So that's a good question. So recurrence rates for carpal tunnel syndromes are low, but it can happen. And the most common factors for repeat surgery is risk factors such as diabetes or low thyroid function, we call hypothyroidism. Also, rheumatoid arthritis are higher risk factors. However, the likelihood of recurrence is relatively low, and if we do see it, it's usually more about 10, 15 years down the road. It is uncommon to see it within the first 5 years. Can it happen? Sure. But it is not very common. So it's more about 10, 15, 20 years down the road. Can you see a recurrence? Then that's possible. And the treatment would be the same. We just go back in there and re-release the carpal tunnel. Usually the reoccurrence is related to scar tissue as opposed to the ligament reforming. However, you can see the ligament reconstitute itself as well. And so the surgery would be to go in there, release the scar tissue, and release ligament if it's still present. So that's a good question, though. Okay. Any other questions for me? No? Great. Well, I'd like to thank you again for joining me. If you have any other questions for me, maybe they could put up my old slide from the last one, and it would be a direct line to my appointment scheduler. And then I'd be happy to see you in clinic, or if you have any questions to my scheduler's email address, you can send that out to me, and I'll be happy to answer those for you. Great. Thank you very much. And do you have if there's any issues or any questions, or any last minute questions there? No? Okay. I guess we'll complete it today. Well, thank you very much, and thank you for your attention.